Hello, my name is Sarah Okot, and I am a certified child life specialist in perioperative service at a pediatric hospital in Phoenix, Arizona called Phoenix Children's Hospital. I currently care for pediatric patients and their families' psycho, social, and emotional needs through education, preparation, and advocacy. I am kind of like a hospital teacher or a coach. I provide information and resources regarding the body, diagnosis, procedures, and healthcare experiences at a developmentally appropriate level. I teach children and their families how to cope with stressful experiences through play, preparation, diversion, distraction, and the use of coping skills. I work very closely with nurses, doctors, and specifically anesthesiologists during anesthesia inductions through both IV and mask in pre-op, peri-op, operating room, and post-op, or what we call recovery after surgery. I empower patients and their families to be brave, believe in themselves, learn, and advocate or speak up. When people tell a child that they cannot, I get to tell them that they can and show them how to do it. You may be asking yourself, what is PPIA? Well, it stands for parental presence during induction of anesthesia. It is a controversial subject within pediatric surgery centers, anesthesiologists, parents, and child life specialists. One either believes or agrees with it and uses it in their practice on a daily basis, or they don't. Have you ever had surgery yourself? Was it when you were a child or when you were an adult? Were you scared? If you were a child, can you remember any positive or negative experiences? A lot of adults have bad memories of surgery and anesthesia from their childhood. Over 5 million children have surgery within the United States every single year, and 50% to 75% of them are very afraid and nervous. For the pediatric population, the process of being put to sleep with anesthesia is a very stressful, scary, traumatic, invasive, and anxiety-provoking experience. The reason behind these feelings and emotions has to do with being exposed to several strangers, being separated from their parents, being forced to lie down, held down, and the stinky smell of the gas. If you have never smelled anesthesia gas before, it smells similar to nail polish, markers, jet fuel, or car exhaust. Some people even say it makes them feel like they are suffocating, and it makes them feel like they cannot breathe. As an anesthesiologist, or what we call the sleeping medicine doctor, they are just one of two or more doctors that the child and family meets within a 2-hour period, not including the 4 or more nurses that a child and patient and family meets right before their surgery. When a child comes to the hospital for surgery, they meet a lot of different people throughout their whole entire day. Within perioperative services alone, from check-in to post-op or after surgery, before they even get to their hospital room or go home, they meet over 15 people within admissions, pre-op, the operating room, and post-op. If the child has to spend the night in the hospital, an average of over 50 new people or strangers and adults come in and out of their room on a daily 24-hour basis. That's a lot of people. This happens because there are so many different departments and shifts with several different employees, volunteers, cleaning people, food services, nurses, doctors, residents, students, orientees, technicians, child life, and all the therapies. As an adult, do you personally like being forced to do something you do not like doing? Of course not. Do you like having the ability to have control over your own environment? Of course you do. As you may know, in the operating room, there are a lot of bright lights, scary looking medical equipment and tools, loud beeping machines, strangers wearing hats and masks and gloves, and there's many moving parts in the operating room. This can be strange, not only for an adult, but even more intimidating for a child. The process of going to sleep with anesthesia is a frightening experience for pediatric patients. The operating room is a new, a foreign, abnormal, and scary place. Fear is seen in almost 50% of pediatric patients before surgery, which has negative outcomes after surgery. Anesthesia induction is one of the leading causes of stress and anxiety that produces negative behavioral reactions within pediatric surgical patients. Anesthesia induction can have lasting negative effects. Most children who have never been to a dentist or surgery center have not experienced the anesthesia mask touching their face, covering their nose and mouth, and forcing strange smelling gases into their nose and their mouth. From my experience and observations as a surgery child life specialist, the children who are the most anxious are actually the ones who have experienced anesthesia induction with a mask in their past. It only takes one negative experience for a child to lose all trust, positivity, and any feelings of safety for future mask inductions. Frequent or chronic surgical patients who have an intense fear of the mask report that they feel like they are suffocating, that they can't breathe, and they sometimes end up having an oral or olfactory aversion to the scent of the mask in the future. Different patients of all ages have reported to me that when their hands, their arms, and head are held down during a mask induction, they feel an intense lack of control because they cannot see what is happening around them and are not sure if they are going to be hurt, poked, or what is actually happening. As you may or may not know and experience on a daily basis with patients, the most stressful and traumatic time for everyone involved within the surgery process is when the child is taken away from their parent. This can be very stressful for not only the patient and parent, but even the medical staff. For all medical staff involved, like doctors, nurses, and child life, seeing and hearing a child scream, cry, kick, and fight can be very stressful and awkward, especially if it happens in between pre-op and the operating room for parents to hear and see. Children experience negative effects when exposed to strangers, separation, and even medical procedures. This all causes anxiety in children. Being separated from one's parents or their primary caregivers can be the most traumatizing for boys between the ages of 5 and 10 years old. Having surgery is already scary, but being separated from one's parent brings upon strong feelings of loss of control and a lack of safety, which is very stressful for both the parent and the child. Being separated from one's primary caregiver has a negative effect on attachment, on bonding, and trust, which are all essential milestones needing to be met by infants, toddlers, and preschoolers. The experience of separation from one's sick, hungry, and tired child has negative effects on parents too. Oftentimes, I see parents crying after the doctors and nurses take their child into the operating room, and sometimes I am the one that walks the family to the waiting room and reassures them that everything's okay and that their child's going to be okay. But they're going through emotional trauma themselves as the parent. The extreme negative effects can be escalated when working with children who reside in the foster and adoption system because these children have been separated from many primary caregivers time and time again. Certain ages and levels of development are affected even more by separation. For example, children with developmental delays like autism and children between the ages of 1 and 5 years old usually have the hardest time with being taken away from their primary caregiver because that's the age where attachment is the strongest. Currently, in medical facilities that do not practice PPIA, there are some alternative methods being practiced, but some are negatively affecting patients, families, and medical staff. For example, more than a third of pediatric patients are visibly and audibly upset during both separation and pre-op and during induction in the operating room, where more than a fourth of them have to be held down and physically confined if not compliant. This act of restraining a child is intrusive, overwhelming, intimidating, and can have moral and lawful retributions. As you may or may not know from personal experience, It never feels good or right to be physically restraining a frightened child in the operating room without their parent there to comfort and console them. For the child, the act feels like a form of punishment or discipline. The last thing we want children to feel at the hospital is shame, guilt, fear, anxiety, grief, and emotional pain. These are the things we want to try to prevent and to heal, not cause. As doctors, which are called anesthesiologists, or the doctors that make you go to sleep, excuse me, you see the patients the day of surgery, and more than likely, you don't see them again after surgery, like at their home or school, unless, of course, they come back for another surgery and you happen to be their physician again. Children can have behavioral issues for days, for weeks, and even months after a traumatic experience in the hospital. Children who have anxiety pre-surgery or before their surgery tend to experience negative outcomes after surgery. These negative results present themselves in developmental regressions with sleeping, eating, and toileting disturbances. Other negative outcomes caused by stressful inductions include anxiety, crying, and emotional outbursts. Anesthesia induction can have lasting negative effects on the child's physical, psychological, biological, and cognitive health. Research has shown that nervousness before surgery is related to both a higher pain scale and a lack of wound healing after surgery. Toddlers through school-aged children are at risk for anxiety and fears of bodily harm, pain, death, and the unknown during the surgical process. What have we seen or experienced in our practices as maybe child life specialists or doctors with parental presence during induction, which is either negative or positive? PPIA supports patients' psychosocial and emotional development and needs. It has positive behavioral effects like cooperation, compliance, and a more smooth and peaceful experience. And children do not trust strangers. So, they cooperate with medical interventions better when their parents are involved in the process. I see this all the time in the operating room. Most 2-year-olds are not going to cooperate well. They're going to scream, they're going to cry, they're afraid, they're separated from the parents. But if a parent comes back, the child actually cooperates a lot better. They feel safe, and their parent knows their favorite song, they feel comforted, and they fall asleep easier and peacefully, and then they wake up easier and peacefully. Most kids who fall asleep upset are going to wake up upset, and it's not a safe or healthy situation. Most children are not compliant with medical staff because of negative experience with injections and pokes. A lot of children go to the doctor for shots, or they have something painful done. So when we see them in surgery, a lot of times when they're taking their temperature or weighing them or taking their blood pressure, they're already crying because they think that a poke is coming. But if their parent is present, we see that they feel more protected, more safe, and more calm. A more calm child creates a more peaceful and positive experience for everyone involved, not only for the patient, the parent, but also staff members. Through research, Ozdegon and associates found that children who did not receive PPIA during anesthesia had elevated biological cortisol stress levels before and after surgery, and the exact opposite was found for children who got PPIA. As physicians, they know how emotions affect our biological reactions, including blood pressure, our heart rate, and oxygen saturation. When our vitals are steady, the procedure is more safe. Fears and anxieties go down when parents are present because they provide a resource of support, of safety, help, coaching, and reassurance for their child. PPIA for anesthesia reduces negative medical side effects like breath holding, laryngospasm, and long-term psychological effects. PPIA is a form of family-centered care. It is a tool that certified child life specialists, doctors, and nurses can use to practice family-centered care, reduce stress, reduce anxiety, and teach healthful coping with patients and their families. The family as a whole is an essential piece of the medical team. since family-centered care has recently become a focus not only within healthcare but specifically within pediatrics. PPIA is one of the standards of practice being looked at, researched, and has recently been developed within local hospitals and child life departments. The patient family-centered care model reduces errors, better improves treatment, and produces contentment within healthcare. Having parents be an active participant in their child's care has positive effects on the child and family's hospital journey. When PPIA is practiced, less medical and less medications and staff members are needed, which saves the hospital time and money. As you may already know, within most of pediatric facilities policies, it states that it is up to the doctor or anesthesiologist if PPIA or pre-medication or another form of support will be used or not. I see this a lot at Phoenix Children's Hospital in the pre-op outpatient surgery center where I work at. Anesthesiologists call the shots in the operating room. So, meaning if they are okay with parents coming back and parents ask, or the nurse or child life advocates for that, then they may allow. Or if they feel like, or they're against parents coming back in the operating room, they may order a pre-medication, so a little drink for children to drink before going back so they don't remember going back, and so that kind of makes them drunk, kind of like alcohol does. Or sometimes an anesthesiologist just prefers child life coming back, but sometimes at certain ages, I am just another stranger. And of course, I would love it if every parent could come back, but that's not even appropriate for every situation either. So every patient, family, and physician and facility is different. Sometimes it can be overwhelming to think of the amount of children and their families that you work with, but you only have to start with just one patient and family. Just try it with one child at a time. Collect your data, both positive and negative, and guild your support group or team. You can't do it successfully on your own as one person. You have to have a team of people that support and help it be successful, positive, and a smooth process. It really does take a village. The presence of a child's primary caregiver, who most often is their parent, can help protect the pediatric patient from traumatic experiences during the induction of anesthesia. Trauma could be caused by fear, anxiety, stress, pain, confusions, feelings of abandonment, mistrust, and guilt. PPIA is a tool used to support and protect patients and their families from stress, fear, and anxiety. It has a positive impact on hospital budget costs, family-centered care, and patient satisfaction. Some positive alternative methods used to ease the stress of induction include a compassionate setting, preparation ahead of time, which is what child life does, building a connection, giving the child control and choices, comfort items from home, like a blanket or a stuffed animal, and sometimes pre-medication. A compassionate setting can be created through a more child and family-friendly environment, like a playroom. The act of preparing a child ahead of time can be done at home, in a clinic, or in pre-op by a parent, a nurse, a physician, and or, of course, a child life specialist. Building a connection takes time, and that is something that is hard to come by in the medical and surgical world because it's so fast-paced. It is one of the hardest things for anesthesiologists and even us as child life specialists to do, since we're scheduled back-to-back with surgery. Sometimes we only have 10 minutes to meet the patient and family before surgery. Giving the child as many control and choices that we can be as easy as letting them choose if they want to walk or ride back to the operating room, sit up or lie down during the induction, maybe what scent they want for their mask, or maybe what they want to eat or drink after surgery. A lot of times I do this with kids. I ask them if they want a piggyback ride, if they want to ride on the bed, or if they want to walk back or race back with me. A lot of kids are afraid to lie down on the operating room table. It's a very invasive feeling. They feel very vulnerable. So a lot of times they advocate for letting children sit up. And then if the hospital has the options to do different scented masks with oils or scented chapsticks, that's always fun for kids to get to pick what smell they want to smell as they're falling asleep. Allowing a child to take their stuffed animal, their blanket, maybe their pacifier, or some kind of comfort item from home can be very comforting in the operating room. Pre-medications can sometimes be given for pre-surgery anxiety, but not every doctor, facility, and patient are able to give these medications for many different reasons. Don't be afraid to try and trial. Survey your patients and families who use PPIA and those who do not. PPIA is not for every patient and family, but it's worth educating, preparing, asking, trying, and looking into other positive options.